Ma'am, we are already live, so with all your due permission, can we begin?
Yeah, please.
Ma'am, please turn on your camera.
Where is it? My camera, I can't see you. Nothing I can see here. It's okay, yeah, you start up. No. Where is it? I don't see any icons here.
Ma'am, the camera icon that is there down below.
It's not there. Nothing is seen now. It was there. Now I don't know what happened. It's not there. Only
You just scroll on your screen. Just put the cursor on your screen.
yeah, I have done. No, it's going up. It's not coming there. Anyway, it's okay. You start already. We are late, I think. It's coming and going off the icons. I don't know what has happened to the other side of the screen. I don't know. Now, suddenly the icons have vanished. Now, if I take off my slides again, I have to go back and come for the screen slide sharing. I'm in a full screen slides. Okay. It's okay, I think, no? Even if I'm not there. You want me to do again? It's okay, no? You start off because all icons have gone off. Yeah, maybe a long time I have been keeping it. Okay, now I do it.
Yes, ma'am. You are visible on screen. Now, kindly share your screen.
But this one is not shared. Now, see, I can't do that. Now the full screen sharing won't come unless I come out and then start doing.
Ma'am, your voice is echoing a lot.
Why? What is happening? I don't know. Is it okay now, the voice?
No. Your voice is coming. Yeah, better. Yes.
Now I can't make it a full screen. That's a problem. Full screen I can't, I think. Okay. Slideshow. Current. Okay. Okay. Is it okay now?
Yes, ma'am. Please start.
Okay. We'll start. Yeah.
Yes, ma'am. Please start.
Okay. Shall I start or you want to start the program?
Ma'am, you please start. There's some problem with the voice connectivity, which is not being able to trace. You please start.
Is my voice heard? Hello?
Better.
Hello? 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 Hello?
Ma'am, audible. Please start.
Am I audible?
Yes, you are.
Okay. You don't want any introduction?
No, you start, ma'am.
Okay. Okay. I'm audible, no?
Yes, ma'am, you're audible.
Okay. Good afternoon, all the viewers. And I thank IJCP Group for giving me this opportunity to talk about.
Yes, ma'am, your voice is being heard.
Okay, thank you. I have been asked to talk about the menorrhagia. Now, my title, if you can see, I have put it as abnormal uterine bleeding. Okay, why I put it purposely is the word menorrhagia, metrorrhagia, all those words have been given up now. And there is a PIGO international classification of abnormal bleeding. And the title for it is now abnormal uterine bleeding, rather than we call it as menorrhagia. That's why I have put this title. Okay. Now, this is the flow of my talk. I think, can you see the slide change, please?
Yes, ma'am, it's visible.
Thank you. So, this is the headings under which I'll be discussing this topic now. Now, these are this is one abnormal uterine bleeding is a one which can happen in every age group. See, these are the common things we see in our practice, day-to-day practice. 15-year-old girl was brought by her mother with a complaint of heavy menstrual flow since 15 days. She attained menarche only 1 year back. Now, there's a reproductive age group woman. Usually, they may come with irregular cycles like 30 to 50 days, or prolonged bleeding, or a heavy flow. One of these things they can come with. Very commonly, we encounter such situations. And of course, perimenopausal women presented with the acute AUB. We'll come to the terminology of what we mean by acute AUB shortly. With hemodynamic instability, she bled so much that her BP is low, her pulse rate is high, she looks anemic. What I mean is hemodynamic instability. Then, of course, postmenopausal bleeding, postmenopausal women, anytime they come with bleeding, that's a cause for concern for all of us. Now, the menstrual irregularities have various causes in different age groups. That we have to remember. See, we said about the 4 age groups we have seen in the previous slide. And in each age group, the causes would be different. So, depending on the causes, the investigations priority will differ, management priorities will differ. Now, seeing it adolescent age group, this is nothing but HPO axis immaturity. That's why they have irregular cycles, prolonged bleeding, or there are no cycles. She would have attained menarche. After that 1 year, she has no periods. The mother is so worried. They come with all this, or she must be bleeding for the last 3 months, madam. It has not stopped. This is because the HPO axis is immature still. So we need to wait for at least for 2 years after the attainment of menarche for the HPO axis to mature and streamline the menstrual cycles. So their assurance is needed. If she's bleeding heavy, probably we need to do something to stop or reduce the bleeding. Now, coming to the reproductive age, always we have to remember pregnancy problems. They may say many a time it's a bleeding for the last 2 months, 3 months. It could have been a miscarriage and she would have been bleeding. Or it could have been an incomplete abortion which she has not realized and she's bleeding. Now, of course, sometimes they do have anovulatory cycles. More than anovulatory cycles, these group of people will have ovulatory cycles with a heavy bleeding. Their cycles are okay, but they have heavy bleeding. And these are the people who have local endometrial causes mainly. Because it's not the endometrium which is proliferative or hypoplastic endometrium or nothing like that. But there is a local prostaglandin imbalance in the endometrium will be there. That causes this sort of prolonged bleeding, or sometimes it's anovulatory bleeding. Now, coming to the perimenopausal age group again, like the adolescent age group, here again, what is happening is this is weaning time, so that the menstrual cycle, the cycles are becoming irregular and anovulatory because the ovary will be losing all the follicles. So most of the time it will become anovulatory cycles. So they have typically 3 to 4 months of amenorrhea followed by heavy bleeding, continuous bleeding, all sorts of things they do come. And a postmenopausal bleeding, whenever they have, the first thing is we have to rule out cervical as well as endometrial cancer. This is the way we need to think of the causes. Now, coming to the AUB, that's abnormal uterine bleeding, 1/3 of the women are affected in a lifetime. Wide variation in the prevalence is due to age factor. 3 to 35%, they say that most of them are in the reproductive and perimenopausal age group, or in the early age, just post-menarcheal age. That's why there is a variation in the prevalence of it. Now, women suffer from disruption of work, productivity, and quality of life when they have this problem. So it's up to us to manage them properly. What's abnormal bleeding? Now, what is abnormal? Before we know, we need to know what is normal. Anyway, there was a 2011, FIGO had given some definitions for this, but now there is again a revision 2018. Now, if we go through the 2018 normal values, then we know what is abnormal. Now, this usually contains any of the menstrual cycle. There are 3 things which we take to call it normal or abnormal. That is the frequency of the cycle, duration of the flow, and volume of the flow, and the regularity of the flow. That means whether the cycles are regular, irregular. If they are irregular, how frequent whether they are short cycles or long cycles. Then, of course, what is the duration of the flow and what is the amount of bleeding they have. Depending on that, we say that it's abnormal uterine bleeding or normal uterine bleeding. If you take that frequency of the cycle in the days, less than 24 days is frequent. 24 to 38 days is taken as normal. If a woman comes and says, no, every 25 days I am bleeding, you have to just assure her, yeah, that is within the normal range. So don't bother about it. Now, more than 38 days, you think that it is infrequent. This is very frequent and this is normal. This is even 2018 is the same. Now, cycle regularity, shortest to longest variations in date. Now, if it's less than 9 days, then the cycles are shorter cycles. And if it is more than 10 days gap between, that means it has to come in 30 days, it has gone beyond 40 days. Or it has to come in 30 days, it has gone less than 20 days. So these are the things we'll say cyclical regularity. Then duration of flow. More 8 days is normal, less than 8 days, anything between 2 to 8 days is normal. We take it as it used to be 4.5 to 8, but 2 to 8 is taken normal because the less than that is given up now. This is not there as a shortened cycle. So more than 8 is abnormal or prolonged bleeding. Less than 8 is normal, and this less than 5 shortened bleeding time is deleted. Anything more than 1 day, she just says, I used to bleed for 5 days, doctor. Now the bleeding is only for 2 days. So it doesn't matter. 2 days you bleed, that's enough. It is a normal variation. That's what it is now. Now the volume of bleeding, this is said that more than 80 ml, 20 to 80 ml is normal, less than 20 ml, just a spotting less than 20 ml, that may be abnormal. But here they say in 18, this is only a patient will tell us. We have no way, every patient, every time when they come, we have no way to assess it, though we have means and ways and means of assessing the blood loss. But every patient who attends the OPD with this complaints will not be able to measure the exact amount of bleeding. So they say that it's a leave it to the patient's determination to say whether she bleeds more, she bleeds less, or she bleeds normal. Now, this is what again the same cycle it's given now. See, flow volume, it is heavy, normal, or light, they say. Now, other thing which is added from the previous table is intermenstrual bleeding. Bleeding between cyclically regular onset of menstruation. So what do we mean by intermenstrual bleeding? She bleeds once in 30 days. She bleeds again in between 15th day, 16th day, 14th day. Many people will come. Intermenstrual bleeding. We used to call it as metrorrhagia. Now that word is given up. Now we call it as intermenstrual bleeding. This is again, it's a random or none. It is not there, or it randomly sometimes it happens, it doesn't happen, or it is cyclical. See that early cycle it can happen, mid-cycle. Mid-cycle is the 15th or 16th day. Usually we call this mid-cycle is physiological because at the time of ovulation, they may have some spotting. So we must know, we must ask them, when do you get this bleeding? You should, she says, 2 months, since 2 months I've been having in between my periods also, doctor, some bleeding I see. We must ask her, this is whether, what is the duration, I mean, when is this, it is happening in the cycle, if she takes, which day of the cycle it is happening, we must ask her. If it is a mid-cycle, most probably it could be physiological. Early or late cycles, we must think of, first thing we should think of at this age, hormonal imbalance. Or sometimes any intermenstrual bleeding, the classical teaching is we have to rule out cancers. So that we may have to think. Then unscheduled bleeding on hormone medication. That's the other thing which was not there in the previous cycle. I mean, previous chart. Not applicable because she is not on any hormone medication. If she is on hormone medication, even 1 day she stops the hormone, she may bleed. Or if she has Mirena insertion, sometimes the spotting is there. And suppose she has taken a medroxyprogesterone injections, depot medroxy injections, there also they can have intermenstrual spotting. So that history is relevant for us. Now, this is abnormal uterine bleeding. In that you have heavy menstrual bleeding, intermenstrual bleeding. Now, this is what is called a palm coin, very famous now, we use that. That means what is the abnormalities, what is the abnormal bleeding is due to what? In that, FIGO has structured it as structural abnormalities and non-structural abnormalities. Under structural abnormality, we get the uterine polyp, endometrial polyps, adenomyosis, leiomyoma, malignancy, or hyperplasia. That is PALM, PALM, PALM. Then coin is coagulopathy, ovulatory dysfunction, endometrial causes. That is apart from endometrial polyp and cancer, could be endometritis. That's the main thing we talk about. Then sometimes you have AV malformations. Iatrogenic is because We have induced hormone therapy we have given, which is not taken regularly. There's something called not otherwise classified. This they are including like this AV malformations and other things, which are very rare, are included into this. So it becomes palm coin. This is the way now the AUB is described, the causes. This is the causes, same thing in a pictorial depiction. This is polyp, adenomyosis, and fibroid or leiomyoma. Endometrial hyperplasia, this is endometrium, this is the myometrium, this is serosa. Endometrial hyperplasia, coin coagulopathy, then ovarian dysfunction, ovulatory or anovulatory. Endometrium, this is endometrium, what they say that endometrial abnormalities like told PG, prostaglandin imbalance in the endometrium. And then iatrogenic is the IUCDs. And non-otherwise classified is what we call it as an isthmocele. Now we call it something called isthmocele. With the cesarean section rate are increasing. When we do cesarean section, at the scar, this is the cesarean scar on the uterus. From there will be bleeding. Now and then she'll have the spotting or continuous bleeding. That's called isthmocele. Okay, so that could be the reason. So these are all the palm coin again. Now this I don't think we need to go into the details. If there are fibroids, how the fibroids are classified now. Leiomyoma subclassification is that depending upon the position of the fibroids, there is 0 to 8. Whether it is totally intracavitary, so partially intracavitary and intramyometrial, or totally intramyometrial, or partially intramyometrial and serosal, and totally subserosal. So depending on that, we have again classification, so that how do we tackle these fibroids, by a hysteroscope or laparoscope, or how? So for decide to that, this classification on the fibroids is given. Now there are some changes in the FIGO classification 18, and before that we said system 2 category ABU-A, and A is adenomyosis. That should be a criteria, should be ultrasound criteria. Now that ultrasound is able to diagnose, before that we used to say adenomyosis only histological diagnosis. We were taught and we were teaching for quite some time, but it is not so now. Good resolution ultrasound machines can diagnose this. So they say that histologically, leave alone histological. Now ultrasound criteria has been defined. If those criteria is satisfied, you can diagnose AUBA. Now AUBL, that is, well, I said now there is a difference in the FIGO classification of fibroids that is depicted in. Now AUBC, coagulopathy, and induced coagulopathy by the drugs. Many patients are on the anticoagulants. So those things are because bleeding because of the anticoagulant therapy are not included in AUBC. Here, previously it was included, now it is not included. What is included is only when they have coagulopathy, von Willebrand's, hemophilias, leukemias, that is all included in this coagulopathy. Same thing in other things also. I don't think you will have to go into the really details of it. Now, this is the way the diagnosis is written. See, diagnosis, abnormal uterine bleeding, choose to, there is no fibroids, but it is a ovulatory dysfunction. That means the lady must be having seeds. There's a fibroid, correct. There's a fibroid, plus there's a thick endometrium. So there are two things. So leiomyoma is also there, that is outside it is. So they have put it as leiomyoma 0, that is FIGO's classification. And the ovulatory dysfunction also, because this cannot cause menstrual abnormalities. Okay, and it cannot cause severe bleeding because it's outside the cavity. So along with that, she has bleeding, so it must have been ovulated. So this is the way we put the diagnosis, the cycle length, regularity, duration, volume, which we just spoke about, that has to be mentioned whether there's intermenstrual bleeding. Now taking palm coin, say palm coin, which one is positive, which one is plus, which one is not there, we have to write here. So obviously your diagnosis, you write it as this. So see here, this is the picture depiction. See the fibroid is here outside almost, which will not cause the menstrual irregularities. So see, the endometrium is very thick. So it could be AUBL and O. So that's the way the diagnosis is given now. Now the types of AUB, as I told you, we'll talk about non-gestational. That means you exclude completely the pregnancy. Then we have AUB, non-gestational AUB, that's called acute AUB and chronic AUB. After excluding the pregnancy, we have two types, acute and chronic AUB. What do we mean by it? Acute AUB is heavy bleeding requiring immediate intervention. Patient has collapsed. See, suppose there is she was on anticoagulant. She comes with severe bleeding and her BP is low, pulse is rapid. So she needs an intervention or resuscitation. That's called acute AUB. So in that, again, you have 3 degrees. Mild is when the hemoglobin is more than 11 grams, moderate 9 to 11, and the severe it is when hemoglobin has fallen to less than 9 grams. Now, chronic AUB is what we usually come across. Abnormal uterine bleeding for more than 6 months. Every cycle, once in 3 months, she gets a cycle, she bleeds heavily. Anything which is persisting abnormal for more than 6 months is called chronic AUB. Bleeding is more in volume, duration, or frequency, or any one of them it could be. Now, this is again the same repetition causes of AUB. 12 to 19 years anovulatory cycles and coagulopathy, there could be. 20 to 39 years ovulatory, endometritis, fibroids, polyps, and sometime IUCD insertion, carpet insertion can cause endometriosis, PID, alteration is neuroendocrine function of the patient can cause. Now 40 years and up to menopause, anovulatory cycles, mostly endometrial hyperplasia, fibroids, uterine polyps are very common in the menopausal age group. Adenomyosis, though not very common nowadays, we are seeing in the postmenopausal women also, we are seeing adenomyosis, malignancy, and women who are on HRT. We have to ask the history whether they are on HRT. Now, how do we approach this problem? Patient has come to us with a heavy menstrual glow every month and hemoglobin has fallen to 8. How do we approach? As we said, a detailed clinical history, including family history, has to be taken. A clinical examination is very, very important. At this juncture, I want to stress upon a clinical examination of the patient. Look for anemia, look for lymphadenopathy, look for hepatosplenomegaly, look for pallor, look for edema. And then a pelvic examination is mandatory. Without doing a pelvic examination, looking at the scan reports, please don't treat the patients. Have to do a pelvic examination. If you are not able to do it, get from your colleagues, ask them, request them to do one pelvic examination for your patient and give the findings. That is very, very important. In the era of ultrasound, people, even the gynecologists, have forgotten to do a pelvic examination, which is very, very pathetic. All of us must do pelvic examination. Now, investigations could be blood investigations, and imaging modality is the main say for us in diagnosing these cases. Detailed history taking regarding the menstrual history, regularity, frequency, duration of the flow and dysmenorrhea, and when is our last menstrual period. Abnormalities in the menstrual cycle, prolonged or shortened cycles, heavy or scanty bleeding, intermenstrual or postcoital bleeding. Then disorder of systemic hemostasis, heavy menstrual bleeding from menarche, whether she has got. If so, she must be having some coagulopathy, PPH, whether she had. If it is she had during her pregnancy, we must ask her. Surgical or dental bleeding, any small cut, she bleeds more, or from the gums, she bleeds. Bruising, gum bleed, and epistaxis, if she has. We have to ask this. These things will say thrombocytopenia. Then personal history, habits. Chronic diseases like thyroid disorders, drug therapy like anticoagulants is very, very important. Then family history of AUB, whether mother had, sisters have, and maternal or paternal aunt had. Then thrombophilia. Anybody in the family has got thrombophilia. Now the investigation, blood test is CBC, thyroid profile. Test TSH is enough initially. If TSH is abnormal, then we can go for thyroid profile. Coagulation profile, especially in younger girls. See, a woman who has got a delivery and she has uneventful pregnancy and delivery, such people, priority is not the coagulation profile. But in a pubertal menorrhagia girl who comes with the excess bleeding, definitely we have to do a coagulation profile. And never forget urine pregnancy test up to perimenopausal age group. Patient may deny, she may promise that she has no possibility of pregnancy, but still it is up to us to do because we have burnt our fingers quite some few occasions. Then blood sugar, then ultrasound, MRI. Ultrasound is enough in most of the cases, especially 3D ultrasound now. And a good sonologist must be there to interpret and give us the findings. Then ultrasound is enough. In some cases like fibroid adenomyosis, fibroid, to classify the fibroids, as I told the picture, and in adenomyosis, for be sure to have that MRI scores over just an ultrasound. Then histoscopy and endometrial sampling, wherever it is necessary, we should not hesitate to do it. Okay. Now the diagnosis is age of the patient is important. Type of AUB, acute or chronic, or acute and chronic AUB. Severity, heavy of the flow, excess flow, or prolonged flow. Then cause, form, coin, whether any one of them is the cause for this bleeding. Then associated medical problems. She has a history of coagulation defects or on medication, anticoagulants or hormones or any endocrine problems like thyroid. Hypo and hyperthyroid both can cause menstrual irregularity. Then ultrasound findings. These are the things we have to do. Endometrial thickening, endometrial homogeneity or heterogeneity, fluid in the endometrial cavity, and then the hyperplasia, cystic places, and the vascularity of the endometrium. All this, just saying that there is endometrium of 3 millimeters seen or 10 millimeters seen is not adequate nowadays. The sonologist will come. You must demand sonologist to give all these criteria, endomyometrial junction, everything they have to give us in the report as far as the endometrium is concerned. Now, role of histoscopy in abnormal uterine bleeding. Histoscopy is the gold standard procedure for endometrial evaluation in a peri and postmenopausal woman. No need to do in a, of course, puberty menorrhagia, we don't do any invasive procedure unless warranted. Even reproductive age, we don't need to do histoscopy. But in a perimenopausal and postmenopausal woman, when ultrasound is done and you are not able to treat or the symptoms have persisted, then there is a role for histoscopy. Office histoscopy is minimally invasive and it's an OPD procedure done in proliferative phase of the endometrium. We have to do it. Indications: postmenopausal bleeding with increased endometrial thickness, premenopausal AUB with suspected intracavitary abnormality like polyp, tumor, fibroid, or something. This can be diagnostic as well as therapeutic because when you put histoscopy, you will see the polyp and at the same time you can remove the polyp. So also the fibroids. Then postmenopausal bleeding with failure to obtain endometrium for histopathology. You have done a DNC, nothing has come, but they said that thick endometrium. There again, we have to do the histoscopy. Persistent heavy menstrual bleeding in spite of medical management. Persistent or recurrent postmenopausal bleeding. These are the indications patient has to be sent for hysteroscopy or we need to do it. Then patient evaluation, high risk factors, family history of malignancy, personal history of malignancy, PCOS, nulliparity, diabetes and hypertension, obesity, and she's on hormone replacement therapy. Or this other thing, lots of people have got a breast cancer now. Very common it has become. And when they are on tamoxifen therapy, you will see a very thick endometrium. So these women on tamoxifen therapy have to be regularly followed up for the endometrial thickness. And some people can get endometrial cancer because of this. Then ultrasound evaluation of the endometrium, as I said before. Any endometrium less than 11 to 12 millimeters thickness, close surveillance is needed in asymptomatic women. In symptomatic women, especially, we have to take a sample of endometrium. If the woman is asymptomatic, but she belongs to high risk factor, she has got any of this, we have to do endometrial sampling. Abnormal features of endometrium is there. That's what I said. Not only the thickness of endometrium, they have to give all the features of endometrium. We must ask the sonologist If we are not doing sonography, we must ask them, give all these details. Then only they learn to give. Otherwise, they just say endometrium is this much. That doesn't mean anything for us. Then reversible risk factors, whether there are any risk factors in her, like obesity is the main risk factor for the endometrial thickness. So reversible, if they are there, we must counsel the patient to reverse it. Okay, that's now this is endometrial sampling has to be done. Where it has to be done, I told you in the previous slide. Where do we do the endometrial sampling? These are all the situations where we need to do endometrial sampling. Any persistent, except puberty, menorrhagia, where we don't touch the girls for a sampling. All others, reproductive age group, in spite of our treatment, if it is persisting, we need to do sampling. Premenopausal and postmenopausal women, when the endometrium is thick, we need to do endometrial sampling. Now, how do we do endometrial sampling? It could be aspiration cytology, pipple sampling, or DNC. DNC, I think for the age-old DNC, we have been doing for the last 50 to 60 years, but now that is slowly is given up. Now, what is more is pipple sampling. This is outpatient, painless, cost-effective procedure to get the endometrium. Now, see the adequacy, 96%, same like our DNC. DNC, you have to admit her, give anesthesia, and nowadays in the hospitals, anywhere it costs them about 30,000 to 40,000 rupees. Here it costs only 2,500 to 3,000 rupees. Now see the inadequacy, it's only 4%, both are same. So all of us have switched over to pipple sampling, which is easier, outpatient procedure, cost effective, and minimal invasive for the patient. Now the terminology which you use now for the endometrial hyperplasia, when they have got, once we have done a pipple sampling, suppose she has got endometrial hyperplasia, they give us. Now, what is it? There are two types of endometrial hyperplasia without atypia and atypical endometrial hyperplasia. This is the latest. Previous to that, there were 3 categories. We don't use anymore those. This endometrial without atypia is coexisting carcinoma is less than 1%, and it going for malignancy is, see how less it is, 1 to 1.01 to 1.03. That means almost nil. So these patients, we don't say you undergo hysterectomy. We'll give her the oral medication or put in an LNG system, intrauterine LNG system, that will suffice. Coming to the atypical endometrial hyperplasia, this is, see this. This along with that, there can be endometrial cancer in 25 to 33% of the people, or it can become malignant in 45, almost 50% of the women, it can become malignant. So the treatment here, what we propose is, unless they are reproductive age group and they want to have a child, we tell them hysterectomy for these patients. Okay, hysteroscopy advantages, I think I told you that whole endometrial cavity can be visualized, abnormal areas can be picked up easily, directed biopsy is easy. At the same time, we can do the treatment also, polypectomy, and then fibroid removal, all that we can do. The treatment depends on age of the patient, fertility desire, severity of the problem, associated pelvic pathology, and comorbidities, and performance status of the patient. 8-year-old lady comes with the bleeding. She can't even climb onto the table to lie down for the examination. What can you do for such patients? So depends on the performance status also. The treatment consists of medical treatment. In the medical, non-hormonal and hormonal therapy. Hormonal therapy, we have oral injectable intrauterine, that is the Mirena, which I was talking about. Then SERMs are there, endometrial ablation, conservative surgery, hysterectomy, and of course iron therapy and desmopressin. When one milligram is there, desmopressin will be given. Iron therapy because patient will bleed and become anemic. The first line of therapy in these cases is a medical management. We can give antifibrinolytic agents or NSAIDs. Which group of patients? This is the reproductive age group patients. I told you there will be an endometrial problem. That is, there is an imbalance in the prostaglandins in the endometrium. For such patient, the best treatment is this. When you do endometrial sampling in them, it comes as a secretory endometrium. That means it's normal. Why do they bleed? There is a prostaglandin imbalance. Such people we can give NSAIDs. And the other drug which is becoming very promising is tranexamic acid. We can use tranexamic acid. Please, it is given as a pediatric dose. Most of the gynecologists also give at least 2 tablets a day. No, it has to be given 3 grams. Each tablet is 500 milligrams. That means we have to give them 2 in the morning, 2 in the afternoon, 2 in the night. Definitely 40% of these bleedings will get controlled only by the tranexamic acid. If these things won't work, or if patient has got hyperplasia of the endometrium, pathological endometrium, we switch over to the hormones depending on the age of the patient. Now, OC pills can be used, progestogens can be used. Either progestogens can be, as I showed in the previous slide, oral, injectable or LNGs. This is the best. What we use, the woman, if she doesn't need any childbearing, we just put off the LNG system. Once it suits her, for 5 years, she can keep it. And conjugate equine estrogen IV, that is acute AUB, when they come with the severe bleeding, to stop it, we'll give this. GnRH analogs are not used because of the cost, because of temporary relief, and because of associated osteoporosis and menopausal symptoms. Then, ormeloxifene is the non-hormonal SERMs. This can be used for a perimenopausal woman. I don't go into the details of it because time doesn't permit me. So uliprostol we used to use for the fibroids with the bleeding, but uliprostol is out of circulation now because it has got a lot of effects on the liver. Liver function derangement will occur, so uliprostol should not be used. Now, tranexamic acid, how it helps? It is an antifibrinolytic agent, or it stabilizes the clot and reduces the bleeding, and has a general hemostatic effect and has minimum adverse effect. So the dose is, as I said, 3 to 6 grams per day. Should not be used in children below 15 years of age. We should remember that. Now, anti-inflammatory, non-steroidal anti-inflammatory drugs. This is the mechanism how it stops. Progesterone increases arachidonic acid. Arachidonic acid is converted into cyclooxygenase, and this produces prostaglandin, thromboxane, and prostacyclin. Now, here this anti-inflammatory drugs, non-steroidal, NSAIDs, here it blocks the cyclooxygenase pathway, and then it elevated in women with menorrhagia. The PGs are elevated, prostaglandins, and then it controls the bleeding. Now, the imbalance will be corrected, and prostaglandin, thromboxane, and prostacyclin, this is dilator, vasodilator, this is vasoconstrictor. When there is a imbalance, bleeding will be more. So it maintains the bleeding. It reduces the menstrual flow by reducing prostaglandin levels. Useful in AUBE, endometrial causes. Reduces the associated dysmenorrhea, pain. Mefenamic acid is mostly used for this. Now, hormonal therapy, progestogens, suppresses the endometrial development, re-establishes predictable bleeding pattern, and decreases the menstrual flow. Even oral contraceptive pills also can be used if it is not contraindicated. Many people, estrogen is contraindicated. That time we use only progesterone. Otherwise, we can use the oral contraceptive pills. Best thing would be insertion of the LNG-IUS, that is intrauterine device. Then depomedroxyprogesterone. In some patients, we do use this, but the problem is breakthrough bleeding can happen with this types of progesterone. I don't think we need to go into the details. How do we give the progesterone therapy? You can give cyclical, 5th to 25th day, we will give usually. This is the doses what we use. This is the Marina, it is called intrauterine device. We can put it. It contains 52 milligram of levonorgestrel. 20 micrograms per day is released. So side effects, systemic side effects will be very, very less. And it's good. It can act as a contraceptive as well as controlling the blood pressure. Now, the contraindications for this is uterine cavity, small uterine cavity, but now LNG systems, smaller ones are also available. We can use it. Acute any infections or liver disease. And then the tumors, hormone producing tumors, hormone responsive tumors. These things, because this contains progestogen, so all these contraindications for hormones is a contraindication for this. Now, endometrial hyperplasia and carcinoma must be, and coming to the conservative surgical, one thing is endometrial ablation is done for all these patients, but we have to be very careful. Before doing ablation, we must rule out endometrial hyperplasia. You should not be doing when a patient has got endometrial hyperplasia, we cannot use ablative therapies. Now, ormeloxifene is the non-steroidal drug. It's a SEM, that means selective estrogen modulator. This has got a lot of good, see, it is very effective. Long-term safety is established, and this is convenience and low cost because it will only weekly dose. First thing is weekly twice, then it is weekly only once it will be taken. Then minimal side effects compared to other hormones. So we can use in perimenopausal bleeding. If estrogen is contraindicated, probably ormeloxifene can be used. Indications for hysterectomy without atypia. Of course, atypia is the indication. On follow-up progression to atypia, if she develops, no histological regression after progesterone therapy, and repeated bleeding or associated fibroids or something she has got, then probably we can plan hysterectomy for this patient. In a perimenopausal woman, of course, what we need to do specifically, it's not LNG system is the most important. And then if there is endometrial hyperplasia with atypia, hysterectomy has to be suggested to her. Sorry. Now, in short, wide range of age groups are involved for this condition. Varied presentations can be there, lack of specific symptoms and signs, and variable ultrasound findings we will get. Good clinical history and correlating the history with the clinical examination findings is very important. Detailed clinical examination, of course, I stressed on that. Ultrasound examinations will support the clinical diagnosis, and correct diagnosis, appropriate therapy to avoid unnecessary interventions like hysterectomy. Always the treatment should be individualized, and surgical intervention, if only it is necessary, we need to do the surgical intervention. Unnecessary hysterectomy. She comes and says 2 cycles have been heavily bleeding. She's 45 years. We should not say, okay, you get hysterectomy. No way. We should evaluate her first. And we think that, as we said, first treatment is the medical management. We have to think of medical management. If it fails alternative therapies, we have to say last resort should be the hysterectomy rather than it should be the first resort. Thank you very much, all of you, for patient watching and listening. And again, I thank the organizers of IJCP. Thank you, one and all.
Thank you so much, ma'am. Thank you for such wonderful insights upon the topic that you have shared in. We hope that all your inputs shared by you would definitely help our practitioners in their daily clinical practices. So thank you so much for that. We have received few questions, ma'am. With all your due permission, I would like to put it across to you.
Please.
The first question is, what is the role of endometrial laser ablation in the treatment of menorrhagia?
Yeah, it depends on, that's what I told. Endometrial pathology, we have to rule out. If there is no hyperplasia of the endometrium or proliferative, suppose it's a secretory endometrium when you have done a biopsy. Such people, if they are willing, we can do. But one thing we have to tell them is, in future, if they get any problem like pre-malignant or malignant lesions, the diagnosis will be delayed because of this ablation. Otherwise, it can be done. That's why before doing ablative therapy, we have to rule out every possibility of hyperplasia of the endometrium.
Thank you so much, ma'am, for answering the question. We'll move to the next question that we have received. And the question is, what is the significance of previous medical or surgical procedures, diagnosis in the evaluation of menorrhea?
Yeah, see, thyroid problems, medical, it has got an effect on the endometrium, bleeding. Okay, hypothyroidism, I told in my talk, it can influence the thing. Any previous medical history that she has on anticoagulant for some reason, or presently she's on anticoagulant, that also impacts this, a treatment modality. Suppose she had fibroids or she has taken out the fibroids, submucous fibroids, say, that we have to know, because maybe those are the things which again are cropping up because the recurrence chances are very high for this. So a detailed history always tells us how to plan, to diagnose the problem and sometimes how to plan the treatment. So for these things, it is important. Sometimes iatrogenics, and she had a copper T inserted, she had heavy bleeding. Now she comes after the second child, she comes again, she wants some contraception. You can't put a copper T for her because she bleeds heavily. So you must give some other method of contraception for her rather than insisting that, no, you get a copper T done. She says that when I have it, I have a problem. So all these things will help us. Anyway, anything, the whole history when you take, it gives us some clues for us to come to the diagnosis. That's important.
Thank you so much, ma'am, for answering this question. We'll move to the next question and the last question for today's session. And the question is, what are the factors that affect the successful treatment of menorrhea?
Proper diagnosis and a patient's hormonal milieu. See, she's obese. You try to give a lot of therapies. It will not help because she is producing a lot of estrogen in the periphery, in the fat. How much ever you try to give the therapies, it may not be as successful as in a lean woman. And then coagulopathies. I have patients of coagulopathy. Every now and then they come with the bleeding. Okay, and the perimenopausal woman. Because of this anovulatory cycles. Of course, we do for that all this now we manage with the intrauterine LNG system. So that takes care of it. But the obesity is the main thing. And she's on anticoagulants. She's on some drugs which can cause more bleeding. So those things, because she cannot be coming out of those drugs. So, and you will not be able to manage it. And the coagulopathy, I had patients with thrombasthenia. That means a platelet disorder. It's one of the rare platelet disorders. I had 2 patients. Ultimately, their hemoglobin would go down to 4, 5, and platelet count will be 12,000 and 15,000. You can't even touch them for surgery. Ultimately, one patient, I just pulled her on throughout her pregnancy. She wanted children. After that, we couldn't control it at all. Repeat it. Whenever platelets drop, she comes with the menorrhagia. I mean, abnormal uterine, excess bleeding, heavy menstrual. What did you do? Ultimately, somehow we kept our fingers crossed and we did a hysterectomy for her. She went home. Okay, say when the platelets are high, a little bit high. At that time, with keeping all the platelets and the blood products, other blood products, you just operate on them and take out. So sometimes the anticoagulants, they cannot stop anticoagulants for the lifetime because they are on the stents. And they come with the bleeding. You have to take a chance and do off the hysterectomy, or ablative procedure is the best in them. Those are the other indication of some question was there, ablation. In such people where the surgery itself is a dangerous thing for them, we do ablative procedure in them. Whatever be the risk of endometrial cancer afterwards, it's okay. But presently, we have to tide over the situation. We can't do surgery on her. Whoever is unfit for surgery, if they don't have hypoplasia, we can do ablative therapy in them because it can be done under local and no problem will be the intrauterine burning, that's all it will be. So we can do off ablative. Like that, sometimes in spite of it, they bleed. So in a younger age group, even ablative procedures do fail. So we may have to resort to hysterectomy. So those are the people which, in spite of our therapies, they don't respond and they will ultimately land up in hysterectomies.
Thank you so much, ma'am. Thank you for answering all the questions. That was the last question for today's session. And at the outset, I would also like to thank all the viewers who have joined our platform for this better exchange of knowledge that has been shared by you. So thank you so much, ma'am, for your valuable time. And we will be hoping to hear you out more in your future, ma'am. Thank you so much.
Thanks a lot. Okay, thanks.
Thank you, ma'am. Bye-bye.
Bye.